Okay, guys, hi. How is everybody doing? I'm gonna try to move this little thing to the side as much as I can. Okay, so in this video, we're gonna be discussing anxiety and obsessive compulsive disorders as well as other related disorders. The learning objectives for today's lecture is, when you're done, you should be able to describe the impact of anxiety and obsessive compulsive disorders and related disorders on client overall health, explore epidemiological and etiological risk factors that contribute to the client experience anxiety or excessive compulsive related disorders, differentiate the clinical presentations, explore the roles of the nurse, and apply the nursing process through use of clinical judgment functions while providing care to clients experiencing anxiety and obsessive compulsive disorders. So in this lecture, ATI has kind of talks about a ton of different things. ATI is talking about anxiety, obsessive compulsive disorders, as well as other anxiety related disorders like phobias, panic attacks, panic disorders, separation anxiety, this, that, and the third. A lot of it does become repetitious, and so I'll repeat a couple of stuff, but I'm not going to repeat everything just because I don't want this to get really monotonous and lose your focus. So I am going to try to keep this under 30 minutes, but let's get into it. Okay, so when we talk about anxiety, anxiety is a normal response to stress and a common human experience. Feelings of worry, fear, or being nervous in a threatening situation or stressor describes anxiety. So everybody has anxiety, okay? What causes people to have anxiety? Well, maybe going to school, having a test, maybe it's graduation season. So going to someone's graduation, anxiety can be something that's good. Anxiety can be something that is going to evoke fear or worry. But anxiety is a way of life, and so having anxiety is okay, but it's when that anxiety takes away from the person's functionality is where it becomes an issue. So I will talk a lot about patients that I have taken care of that deal with some anxieties. And so to help you kind of understand some of these things, okay? The impact of anxiety is evident when physical and emotional manifestations become overwhelming, even in ordinary situations, okay? And so I think I have many of you who I had in pharmacology, I told you guys that I had postpartum anxiety. And so postpartum anxiety for me was felt when I was simply going grocery shopping or leaving my home and I was having like anxiety attacks when I was out the house longer than 10 minutes. And so it became I was unable to function. I wasn't able to leave the home unless I had my husband with me. I stayed inside a lot just because I couldn't physically leave my house. And so that would be a situation where I am having physical and emotional manifestations that become overwhelming in ordinary situations, just like leaving the house. So we are going to look at this case study a little bit and we'll talk about it. This case study will focus on Sam, a nurse working at a local urgent care center. Sam has been a nurse for 10 years and has worked in this urgent care center for about 2 years. During any clinical days, Sam will see several clients. A few of the clients Sam will see today will include LaShonda, a 14-year-old female, Rusty, a 43-year-old male, and Mason, a 32-year-old male. All right, so when we talk specifically about anxiety, again, we talk anxiety is often experienced when one anticipates a threat or is just experiencing a stressful situation. And anxiety doesn't always have to come about by a threat or something that is negatively stressful. Getting married is a positive stress. Having a baby is a positive stress. Graduating is a positive stress, but this can evoke some anxieties in somebody, but they're not necessarily negative. Occasionally, anxiety may occur for no identifiable reason. So, somebody may have anxiety, may feel worked up, but there's no true trigger that's causing them to feel worked up. So, when we talk about anxiety, and I'll make this a little bit smaller, you can kind of see this little uh, image here, and the person can have a trigger, and a trigger can include anything: health issues, medication, stress, lack of self-care, whatever, right? Then the patient that trigger is going to evoke an anxious thought. I can't do this, I'm going to fail, they don't like me, whatever. Okay, and then it's going to evoke emotional feelings. So fear, worry, panic, anger, all of this is going to arise from anxiety. Physiological response, this is increased heart rate, sweating, feeling faint, nauseous. And then behavioral response, what is the person going to be doing in response to all these things going on? And this can be avoiding situations, withdrawing from people. Aggression are also behavioral responses that are seen with anxiety. Okay, so let's go ahead and maybe give us a little example. So for nursing students, you guys have lots of exams, right? So a trigger can be, oh my God, I have a whole lot of stuff to study and this is really stressful. Anxious thought, if I don't study all of this stuff, I'm going to fail. I'm never going to become a nurse. I'm not going to live up to my goals. I'm going to be stuck doing blah, blah, blah for whatever. Feelings and emotions. Now you're going to start to have panic and worry and anger and fear. From all that, you're going to have elevated heart rate. You're going to have increased breathing, increased blood pressure. You may have sweating, may feel nauseous. Behavioral response, you may get really, really angry. You may get really, really sad. You may avoid or stop talking to people. You may do things that, like, engage in a substance. This is the behavioral response to help mitigate these feelings and anxious thoughts, all from the trigger of you have an exam coming up or whatever. Okay, and so this is like this can become worse and worse and worse. And so again, like we talked about, you see this repetition. Anxiety or response that's based on the person's experience of stress. Like stress, anxiety is a survival response that helps the person avoid threatening situations by causing feelings of fear, nervousness, or worry. Okay? And so early effects of anxiety. What is someone going to feel when they have early effects of anxiety? So they're going to experience increased blood pressure, muscle tension. They may have brain fogginess, which is going to can initially increase the ability to function and increase thinking and increase performance, but as they become anxious for a longer time, it's then going to, the patient is going to feel decrease. So then they're going to have the brain fog. Then they're going to have the decreased ability to function, the decreased ability to think, the decreased ability to perform, and the decreased ability to just function. Okay. So early anxiety is okay. Anxiety can be a good thing. It can be helpful, but the longer we stay in that anxiety, then it can be detrimental. So I think we've talked about this before, so make sure that you remember the Selling's general adaptation syndrome. This is the alarm phase, resistance, and the exhaustion phase. We talked about this in fundamentals. You talked about this as well when we talked about stress. So just remember, the alarm phase is when the body is exposed to stress. The resistance phase is the body is able to stabilize and repair itself. And if the person continues to feel the stress, then the patient's going to be in the exhausted phase, and the body finds itself depleted from energy reserves. Okay, so please make sure that you continue to remember this. Now, when we're talking about Pablo's theory of interpersonal relationships, this all is the nurse-client relationship, so make sure that you remember that as well. When we're talking about different types of anxiety, so the person can have mild, moderate, severe, or panic anxiety. Panic anxiety is not the same thing as a panic attack. Okay, this is just their anxiety at a panicky level. So we talk about mild anxiety. Excuse me. Mild anxiety begins to demonstrate the visible manifestations of anxiety. So restlessness, seeking attention, requiring approval. The person does have heightened thinking, becomes more focused, senses become more elevated. Sometimes this is really, really good when someone has mild anxiety because it can sometimes help them perform better. Okay, so this level of anxiety would allow the student to study more effectively for an exam. But when that mild anxiety becomes moderate anxiety, then it starts to become a hindrance, okay? So the person may feel on edge, may become easily frustrated, have moments of increased restlessness. They may have difficulty with sleeping, decreased concentration, increased worry. These folks may toss and turn, thinking about losing a job, thinking about the world events, thinking about an upcoming test. Then we go into severe anxiety, and this is decreased cognition, irritability, anger, and this person may have an intense feeling of dread or doom. Okay, so when we get to the severe anxiety, this is that intense feeling or dread or doom. It's when we get to panic, is the person has reaches a point of exhaustion. They're no longer able to process the stimuli from the environment around them. They become detached from the reality and may be at risk for self-harm. So between severe anxiety and panic, these can be like emergent like situations, okay? But panic is when, they may have this derealization go on. They are not able to communicate their feelings, and then the self harm is our priority for this as well, because we don't want them to harm themselves. So when we're thinking about anxiety level, we can think about like gasometer. I don't know what the gas tank is called. Is it called a gas tank? I don't know. Low, moderate, severe. This is how we can measure anxiety. Okay. Okay. So when does anxiety become a disorder? So when is it? This is now a mental health concern. Okay. So it's when feelings of anxiety occur at inappropriate times or situations, frequency of anxiety increases, the intensity of anxiety affects the person's ability to function, the duration of anxiety becomes increasingly prolonged, and this is when it becomes a problem. Okay, so this is when the patient probably needs to see a psychiatrist, their primary care doctor, psychiatric mental health nurse practitioner to maybe get some medication, or hopefully just go see a psychologist or a talk therapist and get some good old-fashioned cognitive behavioral therapy to help with, after they have the trigger, to help prevent negative thoughts or anxious thoughts that are going to prevent feelings of emotion, the physiological response, and the behavioral response. So if I have a trigger right here, if I have some CBT skills that I add right here, I may not even get to here, which is going to keep my anxiety level at a low. Okay, I'm hoping this makes sense. I hope everybody's saying, oh yeah, I get that. Okay, so ATI is going to kind of switch a little bit, and we're going to talk a little bit about obsessive compulsive disorder. So obsessive compulsive disorder, some people may understand this as OCD. Okay, OCD occurs when one experiences obsessions, which are persistent and recurrent thoughts or urges that are unwanted and become intrusive. Compulsions or repetitive behaviors are performed by a client who has OCD to lessen or prevent anxiety brought on by their obsessions. Okay, and so I'll give you a little transparency. I had a pretty traumatic childhood, and from my PTSD, I also developed OCD and dealt with OCD like behaviors for, I would probably say, about a good 7 years. And so I'll talk to you about some examples of obsessions and compulsions, and how it can impact someone's life. Okay. So when we're talking about obsessions and compulsions, the biggest thing that can happen is that the obsessions and compulsions can become time consuming and can interfere with the client's ability to perform daily tasks. Please understand, individuals with OCD know that their thoughts and behaviors do not make sense. They know that they don't make sense. They are compelled to do them and unable to stop. The reason why they're doing them is I'm not too sure if maladaptive behavior is the most appropriate term, but it's this behavior that's helping to prevent anxiety. Okay. And so a patient may have a generalized anxiety issue related to whatever, and now they have obsessions and compulsions to help them with their anxieties. Okay. All right. But they're very well aware of what they're doing. They are compelled to do them and unable to stop. Okay. So what are some examples of an obsession? Thoughts about being harmed or harming someone else, fears of safety, concerns for cleanliness or germs, fear that they're offending a higher power or entity, fear of forgetting something important, worrying about how tidy or neatly arranged some items are. Okay, and when we talk about obsession, this is not okay. I'm thinking about this 3 or 4 times a day. This is a constant thought. These are constant. Okay, and they're constant, and they are urges that are unwanted and become intrusive. So they're constantly, persistently thinking about these things. When we talk about examples of compulsions, checking and rechecking that a door is locked, ritualistic order for hand washing, repeating specific words or phrases, hurting self, such as hair pulling, counting objects, items, or actions, and repeating an activity for a specific number of times, okay? And so for me, I had a compulsion or an obsession. I had a fear of safety, and then I had a compulsion of checking and rechecking that the doors are locked, and I had a specific number of times that I had to do this. And so this is before I went to bed. I always had a fear of safety. I always had to get up and close my door. All doors had to be closed. All doors had to be locked. And then I was not able to go to sleep unless I checked that the doors were locked and closed and the whole room that I was in was dark at least 5 times. And I knew that it was silly, and I knew that for me it was dumb and I didn't need to do this, but I would be physically unable to go to sleep unless I checked the doors that were locked, and unless I turn the lights off, everything at least 5 times. Okay? But I got some pretty decent therapy and some meds, so I don't do that anymore. All right, so we're not going to have to learn about the diathesis stress model. You can read this on your own, okay? All right, let's look at this case study. LaShonda is an adolescent client, presents with pain in her ankle after tripping on uneven pavement. LaShonda is an accomplished and driven high school athlete and a member of her school's honor society. LaShonda describes herself as a total type A personality. I have my very strict routines for studying and practice must be done. I just worry I won't be the best. Family history includes biological parent who has been diagnosed with anxiety disorder. Healthcare provider determines that LaShonda's ankle is sprained. LaShonda says, "Whew, that's good to hear. I don't know what I would do if it would be broken. I don't even want to think about it." After completing the assessment, Sam finds that LaShonda struggles to understand how stress and anxiety might affect her. She exhibits the following manifestations: muscle tension, increased irritability, low-grade headache, having trouble falling asleep with thoughts about the next day, restlessness and feeling a bit on edge, and worrying about almost everything. What do you think she is dealing with? So, how should Sam explain to Shonda why she might be experiencing some of these manifestations during her life, and apply the diathesis stress model to explain? So, we're not going to do that. But if she has muscle tension, increased irritability, trouble falling asleep, restless, worried, she is having anxiety. Okay. And what is she? First of all, let's also look when we're looking at this. This is all exclamation points. So she's not even like talking low. She's like shouting this, right? And so she has anxiety, and she also has these strict routines for studying and practice. And so I would want to know, how strict are her routines, right? How much does she have to manage her routines? And if she comes out of her routines, is that going to cause her distress? And if it is, she may also have, an obsession, right? Not maybe a compulsion. She's not checking things, but she may have an obsession with, being very, very strict and regimented. Okay. And so when we're looking at this, we're looking at a case study, we're looking at a question, we need to kind of think, okay, well, what are some of the diagnostic criteria for the things that we're talking about? And how does this patient meet this, not only with what they've diagnosed, but maybe other things that also may be going on? Okay? All right. Oops. Uh-oh. Perfect. All right. Pathophysiology of anxiety. So when we talked about anxiety, the biggest thing is that you need to understand the hypothalamic pituitary adrenal axis. It results in hormone release, leading to the survival mode of fight or flight. Please make sure that you review this, because it can help understand why people get anxiety. Also, there are several neurotransmitters involved with anxiety. And so this is serotonin, GABA are the big ones. Dopamine, glutamate, norepinephrine are also play a part in anxiety. Okay. And typically, if a patient has anxiety, their serotonin levels are going to be low. Their GABA levels are going to be low. Glutamate, I believe, is also going to be low as well. All right. So Sam is evaluating Rusty, a 43-year-old male who is seeking care. Rusty is well groomed, appropriately dressed for the weather, and able to respond to questions. Affect is, remember, whatever Sam sees, the nurse sees. So affect is elevated and anxious. His speech is clear and thought content logical and coherent. No motor slowing. We try not to say retardation anymore, so we just say slowing, okay? So no motor slowing or altered gait. Eye contact is fleeting, meaning maybe they're, looking at a ton of different things, not having good eye contact. Speech is elevated in volume and rate. He is oriented to location, time, and place. Rusty has described his symptoms as, I feel like I'm having a heart attack. I'm nauseous. My heart is pounding. Every muscle in my body is tense. I have a terrible headache. Medical history includes 2 years of moderately impaired anxious mood and worry with frequent visits to urgent care. These manifestations have recently been acutely complicated by new onset of panic attacks. The healthcare provider has ruled out cardiac involvement. So, which of the following manifestations are consistent with severe or panic level anxiety? You go first. So severe or panic level, I'm going to say this nausea. I feel like I'm having a heart attack. I want to say pounding headache, but I don't remember. But for test taking purposes, speech is clear. We know that's out the door, right? Nausea, I remember that. Pounding headache, I don't remember that. I feel like I'm having a heart attack. Yes, that's that impending doom kind of thing. Elevated rate of volume elevated rate and volume of speech, maybe, and no motor slowing. They're not going to have motor slowing. Ooh, I don't remember. So I'm going to go with C, B, and D. We'll see. Oop, and I'm wrong. So then I'm just going to pick C and B, and I'm wrong. So I think it might be all this. Yeah. So the amygdala is a neural circuit in the brain that both informs and influences the manifestations of fear, panic, and phobia. The cortical circuit is associated with those manifestations, associated with worry, apprehension, and obsession. This really didn't answer that for us, did it? All right. So when we're looking at anxiety, again, related and triggered by a person's exposure to environmental stress, comorbidities can include manifestations of both disorders occurring at the same time in an individual, which also often results in worsening of the course of either one or both of the disorders. So these are some anxiety transdiagnostic in nature, so obsessive compulsive, panic. All of these disorders can be associated with anxiety or can present as anxiety and really it be something else. So like we talked about earlier, obsessive compulsive disorder, it can present as, OCD, in which it is, but it also has an underlying anxiety component. All right, when we're talking about risk factors are going to include trauma, such as adverse childhood experiences. Remember, we talked about adverse childhood experiences for exam 1. So if you don't remember what those were, please remember to look back. Personality traits or temperament. History of mental health disorder, history of illness such as thyroid and cardiac conditions, genetic predisposition, lifestyle including lack of healthy diet, poor exercise, and substance or alcohol use. As a reminder, when we talked about med-surg, or if you can remember med-surg from last semester, you should have learned about hypothyroidism and hyperthyroidism. And a lot of people that have hyperthyroidism, they have low TSH levels and too much T3, T4. Okay. And so these patients can have anxiety, they can have tremors, they can have difficulty sleeping, they can have palpitations and sweating. All of this looks like anxiety, right? And so providers will typically go ahead and before saying, oh, you have this mental health diagnosis, they will also try to figure out if there is a medical diagnosis explanation for what the patient is going through. So as a reminder, if you do have a patient that has anxiety or having an anxiety attack, we need to check their TSH levels. A lot of times when people have low blood sugars, they can become irritable and they can have palpitations, they can become sweaty. This is also looking like maybe an anxiety attack, so like a moderate anxiety or severe. And so we need to, check a blood sugar. So we need to make sure that we're doing our due diligence and looking at the patient as a whole versus, oh, you're sweating, you're worried, you have anxiety, here's a pill. Okay, it may be a diabetic issue, it may be a thyroid issue. All right. We already kind of talked about OCD, so we won't go to that anymore. But ATI does talk about some of the etiology and epidemiology around it. And as a reminder, females are more prone to be diagnosed with obsessive compulsive disorder compared to males. Okay, so that's just one little tidbit for you to know. Comorbidity, same thing as before. You can review that on your own. And risk factors, literally the exact same thing. There's nothing much that is different. Please make sure that you review what a modifiable risk factor is and a non-modifiable risk factor. So modifiable risk factor, we can change it. Non-modifiable, we can't change it. So identified vulnerability gene, we can't change our DNA. Okay, so that's non-modifiable. Cigarette smoking, it's really tough, but people can not smoke anymore. Adverse childhood events. Typically, people cannot change the things that happened to them in childhood, okay? So that would be a non-modifiable. First degree relative, again, we cannot change to who our parents are, right? And so that would be non-modifiable. Parent separation during childhood, can you force your parents to be together and love each other? Absolutely not. Recent job loss. That's a toughie. I think is that the modifiable? Oh, look, it is. What happens if I put this down here? Oh, okay, it'll say no. Okay, so illicit substance use, people cannot use substances. In interpersonal stress, people can change their stress levels. Okay, and so please make sure that you're understanding the, modifiable versus non-modifiable. We already talked about adverse childhood experiences before. If you don't remember them, you can read this part on your own. And then please make sure that you read up on risk factors and positive. So, risk factors are going to be our adverse childhood experiences, and our positive childhood experiences, make sure that you review these. Many times, just because somebody has adverse childhood events doesn't mean that the positive will outweigh those and people will not be predisposed to certain things, okay? And so please review this. All right, so you do need to make sure that you're able to distinguish between anxiety and obsessive compulsive disorder, and understand the types of anxiety disorders. So what do you need to know? You need to make sure that you know what anxiety disorders are. So it becomes a disorder. Always know it becomes a disorder when it interferes with daily life, relationship, and the ability to function. So we can talk about, a patient that is anxious, and because they're anxious, they can't go to work, they can't do their things, they're failing school, they're not performing well at work, they're not performing well at home, they are having an inability to function. It is messing with their ability to be successful in whatever they're doing. Okay, when we talk about separation anxiety, this is an inappropriate, excessive, or fear of anxiety on the separation from those that they are attached to. This a lot of times can be seen in children, okay? And so they may have a reluctance to leave who they're attached to. They may have nightmares or physical manifestations of distress. You don't really need to talk about selective mutism for me, but it is important for you to understand it and read it. When we talk about phobias, these are experience marked fears and anxiety upon exposure to specific objects or situations. So animals, nature, heights, inoculations, which I don't know what this is. Let's look this up. Inoculations, inoculation is a process of introducing a pathogen or antigen into a living organism. So let's look at phobia. An intent to fear of needles, particular medical settings like vaccines. Oh, okay. So patients that have the phobias are going to miss vaccines, delay medical care, isolation. Okay. And treatment, gradual desensitization, cognitive behavioral therapy, and medication. All right, cool. And blood. Social anxieties. These are marked fears upon exposure in social situations, scrutiny associated with them. This can include meeting new people, being observed eating or drinking, or performing in front of others. When we're talking about panic disorder, now make sure you understand when someone is having a panic attack, many times that when someone is having a panic attack, this is usually an unexpected and occurs for no apparent reason. Panic attacks may be an aspect or any anxiety disorder. Okay, so somebody may have panic disorder and it also has an underlying generalized anxiety disorder. And as a FYI, this is unexpected. So my professor gave the thought process as someone is sleeping and they wake up in panic feeling like they're going to die. Okay, that's just like immediate. Okay. Agoraphobias, please make sure that you review this and make sure that you review generalized anxiety disorders as well. Okay. There are also types of obsessive compulsive disorders. So we have obsessive compulsive disorders. These are experienced patterns of uncontrollable obsessions and associated compulsive behaviors or rituals. So manifestations include cleaning, washing hands, ordering ordering or counting objects or behaviors or taboo or forbidden thoughts, okay? And then when we talk about body dysmorphic disorder, a lot of times this is like excessive grooming. Skin picking is like a big one. And for sometimes, and I think I'm right, but I might be wrong. You're not tested on this, but I think naltrexone can be given for skin picking because it takes away the craving to like pick. I might be wrong at that. And so these things that I have highlighted, please make sure that you review them, okay? I'll show it to you just for a second. You take a picture of this so you know to go back and review it. All right. So make sure you review the DSM criteria for the things that we're talking about. So for the panic disorder, remember it is it's reoccurring and unexpected. For this to be considered a panic disorder, I believe it has to happen. What is it? This says at least one attack has been followed by 1 month or more of one or both of the following. Okay, so persistent concern or worry or significant maladaptive changes. And they're probably going to have this palpitations, sweating, so on and so forth. Okay, so make sure that you know this. When we go down to generalized anxiety disorder, now look at this. Generalized anxiety disorder, in order for it to literally be like something that's diagnosed, it has to occur more days than not for at least 6 months. So if somebody, if you guys were in pharmacology last semester and you're like, oh my God, I think I have an anxiety disorder, and then all that anxiety has gone away, well, your anxiety was literally based on the class, right? Not necessarily having an anxiety disorder. When we're talking about symptoms, restlessness, easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance. And when we're talking about generalized anxiety disorder, not pneumonia. Here we go, mnemonic. There's some pretty cool mnemonics to help you learn what some of these are. And Dig Fast is the one that I know that I really like. And so Dig Fast is, Dig Fast is for mania. Hold on. Here we go. This is on Instagram. So Mr. Fisk. So for anxiety disorders, you can remember Mr. Fisk: muscle tension, restlessness, fatigue, irritability, sleep, decreased concentration. Okay, so increased fatigue, increased irritability, increased restlessness, increased or decreased concentration. Okay, and so you can take a picture of this as well, and this can help you with knowing the symptoms. And then when we talk about obsessive compulsive disorder, remember, we're just generalists, right? So this is repetitive behaviors and repetitive persistent thoughts. Okay. Okay, so let's look at this. Match the clinical exemplar to the symptom. Lori struggles with worrying about multiple aspects of their life with limited ability to control their sense of worry. Which is that? Excoriation, obsessive compulsive, social, agoraphobia, generalized anxiety, or hoarding. I'm going to go with this. How do we do this? Right here. All right. Surrey exclusively avoids situations where they might be inclined to be the center of attention. And which of these are they going to avoid social situations? It's in the word, social anxiety. Oops. Joseph obsessively picks at their acne at the point of infection. This is excoriation. Okay. Jolene lived in a profoundly cluttered home with limited ability and willingness to part with their possessions. This is hoarding. Okay. Sean endorses exquisite fear and anxiety associated with being placed in a MRI tube. This might be some agoraphobia. And then Shonda struggles with their schedule because they must check all electrical devices, windows, and locks 5 times in a particular order before they can leave home. So remember, this is very particular. A lot of times it has a number associated with it, and patients know that they have this, but they just can't stop. And this is our obsessive compulsive disorder. All right. So nursing, what can you do? What can you do as a nurse? Now we've talked about it. What do you do as nursing? So when we're talking about nursing, just like we can use trauma-informed care, okay? We talked about trauma-informed care, making sure that we're caring for the client without triggering the client, okay? We can also project the sense of unqualified acceptance of and goodwill towards the client to help minimize potential for shame or stigma. So it's not our job to judge people. It's not our job to, reprimand people. It's not our job to wag our finger at people. It's our job to care for people. Okay. So having an unconditional positive regard is a technique that leverages complete support and acceptance of the client and the things that they're going through. And then we can have empathetic linkage. And so this is a self-awareness and information. The nurse can quickly find themselves in turning the client's manifestations and manifesting their own anxieties. So being able to personally identify and with and experience feelings of the client's experiences. So this is essentially just having empathy for somebody can be also helpful. This is talking about transference and countertransference. We've already talked about that. And so interventions, what can nursing do? So active listening is something that nursing can do. It is helping to maximize the social connection and understanding, therapeutic communication, being mindful of clients' clinical presentation and adapting their communication strategies with the patient. And this can be done by simply not using any medical jargon and making sure that you are being professional and open with the patient, modeling, demonstrating kind behavior, always making sure that we have good milieu environment. And so just making sure that the environment is safe. ATI gives an example of the ER nurse elects to move the client struggling with severe anxiety away from the nurse's station and resuscitation area to reduce stimuli. And that's perfect. Anticipatory guidance, and so just helping the patient to address future challenges and complications. Anti-stigma messaging is also a consistent pattern of communicating that aspires to correct misinformation, challenge negative attitudes, beliefs about mental illness. And then you can look at some of these further. When we're looking at our nursing diagnosis, we always want to assess the patient. What clinical manifestations are they, do they have? What's their health history? Have we done a thyroid test? Have we done a glucose test? Have we done an ECG? Is this anxiety or whatever the patient is going through related to substance use? And that's where our toxicology screen comes in. Doing a really good assessment is going to be helpful to just gathering our information. We can also use certain things like screening tools like a generalized anxiety disorder screening, a Hamilton anxiety rating screening. There's one for, they don't have it up here. But I do have the GAD-7, Generalized Anxiety Disorder 7 questions for anxiety. And this essentially is what it looks like. And so as a reminder, you're going to have to interpret these. And so you need to make sure that, you review this and kind of, see how somebody can be dealing with anxiety. And this can be a good screening to decipher if someone has generalized anxiety disorder or is high risk for it. when after we have, assessed, we're analyzing, thinking about ways to reduce symptoms of anxiety, identify a plan for support, and then an anxiety care plan is going to be really helpful. We're going to do a couple of these in class, and so this is kind of an example of one, and so please look over this. And then evaluating, was the things that I did helpful to the patient? We can also utilize interdisciplinary teams and collaboration to help with patients and, some of the things that they're dealing with. All right, so that was pretty much about it. That was our anxiety disorders and obsessive compulsive disorders and related disorders. I hope this was very well informative. I know this was a little bit long, but I did want to make sure that I gave you, all the aspects. You can always listen to this again. You can always listen to this, break it up into 15-minute or 20-minute sessions. Either way, please listen to this, hopefully more than once. If this is your first time listening, I would encourage you to maybe listen again with notes. Do your anxiety engage quiz, see if you learned anything. And remember, if you didn't learn anything, or if you struggled with a couple of things, you need to come back to this and do a deeper dive into the information. All right, I'm going to quit talking. I hope this was informative, and I will chat with you guys later. Goodbye.